Hello, my name is Angela Smiley. I'll be giving a patient report on Miss Maria Smith. Maria Smith is a 56-year-old female presenting to our clinic today with complaints of exertional dyspnea and orthopnea. Miss Smith states that 2 weekends ago she took her 5 and 6-year-old grandchildren to the local pumpkin patch. During that visit, she noticed that she was more winded than normal and had to stop and rest from walking on 3 different occasions in order to catch her breath. The day after, she noted some swelling to her feet and ankles, but attributed it to walking so much the previous day. Since, she reports increased shortness of breath on exertion, chest discomfort, describing it as a tightness rather than a pain. She reports increased swelling to lower extremities and is having problems sleeping at night as she feels she cannot lay flat. Ms. Smith is a long-term employee of an accounting firm where she sits most of the day at the phone or a computer. She does have health insurance. She reports some lower extremity swelling over the past year, but it has generally been relieved with elevation at night and felt it was related to her sitting for long periods at work. Ms. Smith is divorced and lives alone. She has one daughter that lives within 15 miles. That she communicates with on a daily basis. She describes being tired after work and might complete a load of laundry or the dishes before getting short of breath and having to rest. States the last week she has spent most of her evening and nights sitting in the recliner. Ms. Smith states that she has had a dry, irritating cough that she attributes to the dry, dusty weather. Again, she denies chest pain or palpitations, but describes a tightness within her chest, especially with exertion. She denies any previous history of dyspnea or orthopnea. She reports sleeping better with head elevated. She reports a recent weight gain of 6 pounds over the last 2 weeks. Current vital signs: temperature 97.9 degrees Fahrenheit, blood pressure 160/94, heart rate 120, respiratory rate 22. Ms. Smith reports no known drug allergies. She denies latex allergy. She does report seasonal allergies in the spring and fall seasons, which includes a runny nose and occasional cough. Past medical history includes seasonal allergies, hypertension, and had hypersensitive airways as a child, but never diagnosed with asthma. Seasonal allergies are primarily in the spring and fall of each year and have been a problem for over 25 years. Hypertension was diagnosed at age 52 and has had problems with blood pressure medications controlling the hypertension. Her daily medications include Claritin 10 milligrams daily by mouth as needed for seasonal allergies, with her last dose being yesterday. Amlodipine 5 milligrams daily by mouth for hypertension that she was recently changed to approximately 1 month ago after her blood pressure was not controlled with losartan. Past family medical history is positive for maternal hypertension and paternal hypertension and cardiovascular disease. The patient reports the pneumococcal vaccine 2 years ago and the influenza vaccine October of 2021. Social history as follows. As noted previously, patient lives alone, is divorced. She maintains her home indoors without difficulty until the past week. She has one daughter, a son-in-law, and 2 grandchildren. The son-in-law maintains the yard work. Her normal activities include walking in the neighborhood 1 to 2 days per week for approximately 30 minutes each walk. She does not drink alcohol, smoke, or vape. She denies illicit drug use. She normally cooks her evening meals and takes leftovers to work for lunch. But she has had a decrease in appetite over the last week as well. In review of systems, her skin is warm and dry to touch. Nail beds are pink with no clubbing. The head is normal cephalic, atraumatic without tenderness, visible or palpable masses. Hair is of normal texture and evenly distributed. Visual acuity is 20/20 with use of multifocal contacts. Conjunctivi are clear without exudate. Extraocular movements are intact. Pupils equal and reactive to light and accommodation. External and internal ear canals are not tender without swelling. Nasal mucosa is pink and moist. Nares are patent. Small amount of clear drainage is noted. Oral throat mucosa is pink and moist with good dentition. Pharynx is slightly red without tonsillar swelling or exudate. The neck is supple without adenopathy. Trachea is midline. The thyroid gland is normal without masses. Carotid pulses 2+ bilaterally with right jugular vein distension noted. Cardiac external chest is normal in appearance. Apical heart rate 120, regular. S1 and S2 are noted. She is negative for S3. Respiratory, her chest wall is symmetric and without deformity. No tenderness. Fine crackles auscultated bilaterally at lung bases. Abdomen is soft, symmetric, and non-tender without distension. Specifically, no right upper quadrant swelling or tenderness. The extremity exam finds upper and lower extremities atraumatic in appearance. Grade 2 edema to lower extremities with tenderness to left calf. No redness or warmth present to the area of tenderness. Psychiatric, her mood is appropriate as well as her affect. No visual or auditory hallucinations. No suicidal or homicidal ideation. Differential diagnoses for Ms. Smith would include congestive heart failure, pulmonary embolus secondary to deep vein thrombosis, myocardial ischemia, and a calcium channel blocker side effect. In response to the subjective and objective data gathered on assessment, I would order the following. A CBC, which would exclude anemia, which could also be a differential diagnosis. As well, it could rule out any type of bacterial infection. A CMP will evaluate the electrolytes and kidney filtration to see if those would have anything to do with the heart ischemia or any electrolyte imbalances. The BNP, which could aid in the evaluation for congestive heart failure. Troponin, CPK, CPK-MB to evaluate for cardiac ischemia. TSH to make sure that the patient does not have hypothyroidism. A chest x-ray to evaluate for cardiomegaly. An EKG to check for ischemic changes. An echocardiogram to evaluate for heart dysfunction. A lower extremity Doppler to rule out the deep vein thrombosis. If positive, a chest CTA would be ordered to rule out pulmonary embolus. The suspected diagnosis for this patient is congestive heart failure, secondary to a history of uncontrolled hypertension. I would not admit this patient as she is in the early stages of CHF according to the New York Heart Association. She is a class 2, which is referenced in Up to Date. I feel that she can be managed as an outpatient presently. I would change her present medication of amlodipine to a combination therapy of ACE inhibitor plus a diuretic and a beta blocker, also as recommended by Up to Date. The new medication would be HCTZ 12.5 milligrams with less than April 10 milligrams by mouth once daily. I would also add metoprolol ER 25 milligrams, 1 tablet by mouth once a day. By use of these medications, both the hypertension would be controlled and left ventricular afterload would be reduced. Serial follow-up care to evaluate for clinical status, support for health, for heart failure, self-management, including medications, response to therapy, and potential need for changes in therapy. Education would include the importance of daily weight checks, the monitoring of symptoms such as edema and shortness of breath, adherence to a low-sodium diet, and the importance of routine exercise. Ms. Smith has no social, economic, cultural, or ethnic factors that this treatment would interfere with. Potential future consults would be for cardiology and possibly a referral to a cardiac rehabilitation if self-management was not successful. Thank you.